Maybe I will meet many of you in April, but today from Geneva, from Switzerland, let me welcome you. This is night time for you. For me, is in lunchtime. But thanks to technology, we can be connected. And I'm very grateful to Nurul to give me this opportunity, because as I was telling her, it's such a pity that not many dentists have access to this new way of thinking, our profession, because every time I am doing differently what I've been trained in to do as a prosthodontic, I modify in my way, I see the response of the patient. The response of the patient is so, it gives you really the idea, the feedback that we are on the right track. And I don't need a randomized controlled clinical trial, but just observation of the feedback of the patient. So when we thought to bring to Malaysia this concept, the best way is with this course that is called FUNFUNCTION, because you have to think about it that 20 years ago, everything was about aesthetic, beautiful aesthetic, but aesthetic just by themselves, it was not really working, but the patient didn't know, because they were receiving these few very beautiful aesthetic cases, and with time they were having problem. So I started to think aesthetic, yes, very important. I'm Italian. I have and I've been trained by Pascal and Michel Magne. So that was my standard in the 20 years ago. However, I wanted to be biologically oriented, and since the beginning I stopped preparing teeth, considering that my training was American prosthodontics. So I was very aggressive with the preparation, and nowadays I'm totally non-invasive. And I will tell you how and why I definitely confirm after 20 years this choice. But it's not enough. It's missing something. And the idea was function. And I call FUNFUNCTION because when I started, gnatology was considered like, whoa, no, terrible. No, I just do aesthetic. Don't talk about centric relation, Bennett angle, all this complication. That I was also facing during my prosthodontics education. And when you go in private practice, you think that this theoretical concept, how would they apply to the everyday population? And can you do all these like a full adjustment articulator to every patient? Can you do a MRI to check the condylar to every patient? I don't think so. At least I was not capable. So I wanted, on the other hand, be aware of the functional analysis, and that's what I would like to bring to Malaysia in those 2 days with you, 11 and 12 of April. Contemporary gnatology. Why I say contemporary gnatology? Because when we think about gnatology, it's like this, we are so scared, and we say, because the word must be revisited. And the word came from the American university that 1 century ago, they were talking about gnatology, but they were people coming from complete denture that they were trying to balance by subtractive adjustment mouth that they were after that restore in ceramic with canine guidance. All these concepts don't really belong to the way I do dentistry. So what is gnatology? But gnatology is a way to treat correctly this population. And the population that I receive are people that come and they say, I clench. There are people that say, I have all this fracture abfraction at the cervical level. And I'm very gentle with the toothbrush because we always blame too much the toothbrush. I have people that come and say, my teeth are melting down. And I say, is it because it's an antagonistic ceramic reconstruction? I have people with the erosion. Yes, I started with this population, lots of bulimic, but now my population is completely different. I have people that just come to see me because they say I have a headache and they want to know which risk factor I see in their mouth. Because maybe if I change something in their way of function at the oral cavity, there will be, thanks to the trigeminus, there is a huge innervation, a much wider effect on the rest of the body. And now is also this population that I'm addressing, population that we have treated with really heavy, the human body is not meant to have this material in the mouth. Of course, it's better than to have a denture, but how can these people age with time? Do you think this is something that will move and adapt with the adaptation that aging requires? I don't think so. And so that's why we have with these people a lot of problem. And this is my population. And what I see that nowadays, of course, I will never take this patient and remove everything. No, I need to do test drive. And for the people that are following me on Instagram, one of the best test drive that I'm doing is this removable white bite. Is a really snap, it's CAD-CAM monolithic, very thin, and I can change the position of the bite of the patient. And this woman is just saying that she had a headache every day, and with this in the mouth, she remove that headache. So now I have to think about it. How can I give this removable 24 hours attached to the teeth? So this is removable white bite, and it will be the attached white bite. But all this patient needs to be analyzed in a personalized manner. In fact, I do a consultation. 1 hour and a half. Who wants to become my patient must allow me to, not to do a therapy of the problem. I want to understand why the system is failing. Fracture of roots, abscess, mobility of the teeth. I need, if you are talking about the dental problem, but I want to, before start to touch the patient, I need to understand what's going on, the reason, a risk factor that will bring to something like a failure. But now that I know why, I need a project. I need to sit and to change what? The shape of the teeth. I need to change the posterior support. I need to change the anterior, what you call anterior guidance, what I call anterior garage. And I need to understand if this project will work in the mouth. And that's why the therapy is always a test drive where I can always change my mind. And that's why the use of increase of vertical dimension without removing any of the 16 existing restoration, but by recycling them, help me. Because it's not only the shape of the teeth, I sometimes reposition their jaw and I see and I listen to the patient feedback. And it is called functional awareness, because I see more and more my patient, and instead of looking at the teeth, I look a lot to the muscle that they have. And the muscle that I can see very easily are the muscle of mastication, even though I'm extremely important to the muscle perioral, the buccinator, and I'm also very interested to the muscle of the tongue, because we believe that everything is connected. But just to make you understand how diagnosis could be complex, I want to take you I want to make an example that more you go into the awareness, more you realize, wow, that patient, I treat him 10 years ago, and today, ooh, I see so many little details that I was not looking at 10 years before. Everything looks okay, but it could have been even better if I would have been aware. And so let me discuss with you how many therapy. We know there are so many therapy to treat a patient. So we can do nothing. We can do crown and devitalize the tooth. We can do a direct composite. We can do a veneers. There are so many and only we can do so many things to a patient. Ortho, non-ortho. But they taught us that there is only one diagnosis. And I will say no, because I believe that diagnosis is just the last sign that we decide to stop the investigation. And we say, okay, that is the diagnosis. So let me make you an example with ortho. Sometimes orthodontics make a diagnosis included maxillary canine. Okay, that is their treatment would be to pull down the canine. But if there is a little boy next to the orthodontist that pull the leg and say, excuse me, why the canine is included, the orthodontist become aware and he search for a higher reason. And he say, contracted the premaxilla. So he cannot only pull the canine, he has to try to expand the premaxilla. And the little boy, excuse me, orthodontist, why? Because the tongue is not in the right position, so he will not conform the palate. So it doesn't make sense if you open up the premaxilla, but you keep the tongue at the lower position, it will have a relapse. And so the tongue would be also addressed in this diagnosis of impacted canine and constricted premaxilla. But after that, the little kids insist and they say, why the tongue is low? And the orthodontist look at the kids and say, because this guy is breathing not through the nose, is breathing to the mouth, so the tongue is always low. It doesn't matter how much or logopedic exercise you could do if you don't train the breathing, the nasal breathing, everything will be set to relapse. So in our situation, let's think about it, that we have a lot the diagnosis of where. Let's think about it instead of impacted tooth. So this patient, this gentleman came to my office and my diagnosis is broken incisal edge. If I stay at that sign, I will just discuss where to position the new incisal edge, and I will be carried away also to think about the shade. Can we do a bleaching? Which type of shape? And I will tell the patient, let's do an aesthetic mock-up of these 6 teeth and let's make after 6 anterior restoration. Unfortunately, this is 60% of level of awareness that the majority of us stays. 60% of the dentists will just say, Okay, you can have 6 veneers, 6 direct composite, and these restoration are fantastically because the patient wants immediately to receive to address the problem that they came to the office with. However, this incisal edge longer and thicker is set to failure because if the dentist would be in a higher level of awareness, he would have just explained to the patient that the reason why there is a broken incisal edges is because there is no space. And so if there is no space, we cannot make this incisal edge longer and thicker because otherwise they are in a functional conflict. And so this is very difficult because now we have to start looking also at the posterior teeth, and we have to tell to the patient that either we do ortho, or if the teeth are in the right position, we can increase the vertical dimension on teeth that the patient don't think are important. And they don't, because they think the posterior teeth must be restored only when there is pain. They don't think they could be restored even to create the anterior functional space. And there, once you start to look at the posterior teeth, now you have to know how to do occlusal adjustment that the majority of us don't know how to do because we deliver single crown, and the single crown many times is not placed in correct occlusion. And we have to decide which dental material, and we just want to have a contact. So this is the second level of awareness. But there is somebody else that will say, hey, the lack of space is only because of the teeth are too close in MIP, or there is also a dynamic component. And so that's where we start to move the jaw. However, they teach us to move the jaw like this. And if you join me for those 2 days of FUNFUNCTION, you will see that what we see here is not at all how the patient moves during mastication, because this is a motion from MIP out. But when you chew, you are out in, and you activate different set of muscle. But if the diagnosis is wrong dynamic, how this, the mandible I call the car, and the maxilla I call the anterior garage. And the car will be parked many times in the garage during swallowing and during chewing. This situation cannot be good when you have such a deep bite. So you start to tell the patient, you know what? I really would like to address not only the incisal edge, not only the static contact, let's also make you move more freely. And this deep bite is not helping. And what about potential mandibular deviation? Is this an issue? I would say for 60% of the patient, they don't care to stay in a deviated position. But there are some patients, they are really into a zone that they cannot anymore balance their body, that this little deviation can create a big problem. So we need to know that there is a deviation. And after that, discuss with the patient if we, while we are reconstructing the posterior, we want to reposition the mandible straight. And that's what I'm doing with all this removal of bite. I do feedback. If the patient likes, I try to reposition the mandible, and I check if the feedback is correct. I check by myself, and I check with the osteopath. Because again, if you move the jaw, you have this jaw attached to the rest of the body, the cervical vertebra, for example. And once you move this jaw, if you want to make them chew, and that's what I will teach you in the course, we need to have correct way of chewing, and nobody taught us how is the chewing. So we cannot talk about pathology if we don't know how is the correct way of chewing. And all these parameters that they taught us in every training, especially in prosthodontics, now make sense to me, because thanks to all of them, I can understand how I can change the way the patient chew. So there are 3 levels of awareness. If somebody just see this patient and look at the incisal edge, is at the level of aesthetic awareness. If somebody say lack of space, this is what I'm doing. I have been doing for the past 20 years. Create the space by adding not invasive restoration, changing the posterior support to open the anterior garage. However, nowadays, I am in the level of dynamic, and what you saw was a patient to chew, not just a patient to slide on one side, because the mastication is a totally different motion. But there is also level 4, and this is more difficult, because level 4 will bring you together other parameters that we will not address in the 2 days, but I will start to put a little hint on you for the people that are advanced. But we are looking now a lot to the tongue, and we are looking to the TMJ, the vertebra cervical, but we cannot go to a general dentist and start to say, hey, have you checked the tongue? Because this is a progression. But what I want to tell people, please don't stay in level 0. Level 0 is all about final, beautiful picture. We are not photographer of a marriage. We are doctor. And if you are more towards level 3, but already in level 2, there is a lot of satisfaction, and we become more dental medical doctor. And this is huge reward for us because of the patient feedback. So what I just say is that when we touch the teeth in the patient, we know how to reconstruct. People like Pascal Magne, Didier Dici, they have taught us how well bonded to the teeth. That's for sure. However, what I can bring to you is the rehabilitation, because it means that I need to define how was the ability of that patient to function and, let's say, to chew. I need to analyze before I touch the patient, and I need to say, I like that ability. After my reconstruction, that ability must be preserved. I don't like that ability, I will change. And I have, if I go to change against the tendency of the patient to go back to the problem, I have to maintain that situation. There will be every patient of mine comes for a functional control, annual functional control, because we have to think about it. If somebody is at risk of caries, must go to the hygienist even 3 times to have the teeth clean. If somebody is, I have 3 melanoma in my body, I do a checkup with the dermatologist every 6 months. There are people that never see a dermatologist to check their skin. So if you do correctly reconstruction and correctly rehabilitation, we are talking about gnatology. And gnatology that I teach is a gnatology that comes from the chewing. And the most important tooth in chewing is not the canine. The most important is the first molar, because this motion is based on cyclic motion of the first molar. And if you start to see ability of the patient, you start to understand that many people that we define bruxism because they break everything, they are not bruxism. They are just people reconstructed but not rehabilitated, because that reconstruction don't match their motion. And if it's not rehabilitated, even though it's well reconstructed, in my mind, I have this idea, it will fail because it will be in somehow an overload, a functional conflict that will be represented at the level of the weak link. And so we think always that the weak link is the restoration failure. But it's not. The weak link, it's white, restoration, but also the antagonistic excessive wear, or root fracture. This is the white weak link. But we also have the pink weak link. Lots of perio lesions are related to this conflict that keep doing what I call slow extraction. And you remove, correctly adjust the motion of the patient, and you see premolar that they were jingling and they become steady in week, very fast. And the patient does not have any more problem on that. But their motion must be followed, because some of this conflict will come back. And this is the extraoral weak link. Like this woman, they receive a full mouth rehabilitation, reconstruction, too strong, and she cannot breathe, cannot chew anymore. But she's not talking about the teeth. She talks about the pain in the arm, pain in the leg, pain. And these people are considered, most of them, psychotic. And I say, yeah, they become so, they were already fragile, and with the teeth, we gave just the last drops, and they are completely unbalanced. And to bring these people back to a level of comfort is so extremely difficult. But I am publishing an article on the wear diagnosis. It will be out with Quintessence, where I develop a new classification on no Brax classification, because I want to stop defining people Braxes. In that classification, I wanted to talk about the pink weak link, but Professor Belzer, that some of you may know, told me, Francesca, please don't talk about that, because the literature say that doesn't exist unless you have plaque, and it make me remove the pink link. But this is so important, because if we don't know how to identify conflict, of course we cannot see all this problem in this patient. We think is the toothbrush, but once we address, this is the same patient, once we address correctly occlusion, you see that there is no need many times to do major surgery. And I consider my gingiva status the thermometer for functional conflict. So when you see the same patient, here he has the same way of brushing teeth, and here he has the same way of brushing teeth, but I became better in checking functional conflict. So everything beautiful, but we are in private practice, and everybody wants only 6 teeth. So I tell my dentist and the people trained by me, you have to decide. Do you want to just be in level 1 awareness, or you start to move to level 2 that is already hard, and after that maybe you progress, or at least you refer patient, because you don't just say that they are a Braxer because they break everything. Because once you start to see how the system move that the sulcus and the cusp, they come very close, even on the contralateral side of chewing. So this is very sophisticated, and we cannot do on the articulator. The articulator I always say to my laboratory technician, you can only give me 70% of the story. We just need to get the initial position, and the dynamic must be done in the mouth. That's a bad news for us, but this is the only way. So these people, I don't do the rehabilitation on the articulation, and I think I put in the mouth and I don't do anything. No, I need to improve the motion. And during the course, I will explain to you how this motion should be, because we are not carnivore, just chopping. We are not ruminant, sliding everywhere. Some people are out of control. And then we try to put canine to block them, but who's going to protect the canine? We are omnivore. And the omnivore is because the shape must be correct. The Hanau quint, occlusal plane, cusp height, and compensatory curve, Spee and Wilson, that gives you all the inclination of this extremely important, I call ceiling, where the car should make its travel. And so when you look at the, for example, the relation between the upper and the lower posterior teeth, this is I call posterior external garage. And this is the car. This is supposed to be good. But look what we give to our patient. Many times the car is too big or the garage is too small. And so this patient, of course, most probably will break, because if he try to chew, it will hit the antagonistic. But the same things, if we give something too open, this patient will not be guided. They will be sliding everywhere. So there are 3 risk factors that, again, I teach in the courses. That is the wall that people call anterior guidance. I say the distribution of the load and the muscle. The wall could be a natural wall, a deep bite, or created by prosthodontics, ortho, or aesthetic dentistry. This is iatrogenic wall. And what happens if you start to see people chewing, that they need to move their jaw, and the lateral is always in conflict. So whenever you see loss of papilla, inflame, you see flaring, you see a little recession, you better do a test, because we cannot count on restoration. This is broken junction. There was a whole splintered together. The mandible is way too strong in some patients. And so how would you do? You have to do with this GTest. Again, in Malaysia, I really want all the people in the room to chew a gum at the same time, because you need to understand that, again, you cannot close the anterior garage, because once you start to move, you are in conflict. And so if you use the GTest, all of this will be explained very easily. And you will analyze how people move, and you understand that they cannot get longer incisal edge. Load, second point of risk. So I have to, even to speak to my patient, I define the adult, the molar, teenager, the premolar, and here are the children. And the load should not be delivered on the children. So again, how many times we are supposed to have a very light contact, a shim stock passing through the anterior while we are doing MIP. So when I have a failure of ceramic veneers, I cannot just replace and put a zirconia crown because I think this feldspathic was too weak. No, this is a weak link, but I need to see that the adult are not anymore in contact. So I need to address the distribution of the load. And remember, we put a lot of adult not in contact. So they look adult, but they don't behave like adult. It's like everybody has to carry the load, but this adult is in place, but his arm are like here. So the overload is always on the poor teenager and children. So when you go back and see the patient that was the fine Braxer, he does not have posterior support. He has teeth, but these teeth are not in contact, and the anterior, the wall, could be even a minimal overlap. You don't need to have a deep wall because it depends how this mandible move, because there are some mandible that really move very forward, and we have to understand, can we change this motion? It's during mastication, it's not during parafunction. If we cannot, we have to tell the patient, I'm sorry, I cannot give you those 12 millimeter central incisor. But overall, we need to go back to quality of the shape, because we have this issue. On one side, we are making older people with teeth that are too young, and on the other side, there are laboratory technicians that just give shape that don't belong in any human being. And we need to study the beauty of nature. So like we know how is aesthetic in the front, there is a functional aesthetic that should be always in mind, even when we do occlusal adjustment, because something that is shaped correctly has more chance to work better. If it's wrong shape, it cannot work correctly. And the third point is muscle. When you see my population of patients have huge activation, and this is where I'm struggle with, because I know that they, with all the stress in their life, they are overload their teeth. And so when they come to me with this type of mouth, what I can propose and what I can guarantee, because they say, how long does it last? And if the enamel is failing for overload, do we have really the right material? When I see what they do to their own enamel, the enamel is all cracked, but it's beautiful material. So do we have a consensus that the enamel is the best material that you can have overloaded? Ceramic, well, ceramic function, but one day they chop, they chip, they fracture. So they die under overload, has a heart attack. So you don't see that coming. You see the little fissure and it's fracture. Composite, on the other hand, slowly dying, like a chronic disease, like a diabetes. But what is for sure is that these teeth, where you see all this white and an even placed implant, because implant can have loss of bone related to wrong loading, these teeth are really not good for overload. So I definitely need to go for non-invasive. I cannot produce this restoration, cannot, because under load they will fail. And so I need to intervene in this patient. And when I see what they come to me, the patient, I start to read all the weak link, and I start to tell myself, can I change this situation? But I will not fight with harder material, because I need to count on self-adjustment of each patient. So this population, hard on implant and age, is the worst, because when I ask them to feel their body, they don't know at all where they are. So for me, if I can say, I will never do a rehabilitation implant, ceramic or zirconia against ceramic or zirconia. I need to put a weak link. And the weak link should be at least one arch in composite, and that arch will get all the load and it will be remaked, new layer. This is the way I will deal with this population. But when you have natural teeth, like this is normal routine, and you see the patient, and you know that they are going in the direction of, do we do something? We don't do something. So we really don't know what to do. And that's why I need to speak to the patient, to the what I cannot control. And because they want to have, they say here, okay, let's wait. But here, maybe somebody should have done something before. So it's, and are we talking about the anterior teeth, or are we talking about the posterior teeth? And they always ask, okay, the longevity. But for them, they only want a smile. They don't care about the posterior teeth. So that's why first most important person to become aware, it's the dentist. Do I want to put a signature on something that is going to fail, and the patient will be upset, and after my explanation will be like a justification? So I always challenge you, and I say, would you do something here? Because many of us wait, because nobody wants to treat somebody that is overloading and damaging the enamel. But I want to make a diagnosis. I tell my patient 2005, 2025, status quo. And you know I exist, but I exist as a non-invasive, because I will never go and cut this beautiful tooth structure. My goal is to add, before we, even here I will add, I need to add using the 3-step, the method. Some of you have the book, and I'm almost running out of time, so that's not the topic of today. But the idea is global planning. For this case, it's hard to do, very hard, because not only about teeth, but because this patient, you don't know where they are. If they are too close to the red zone, my goal is to take them and to bring more in a balanced situation. And I was telling to Nurul that I have a lot of education, because I went to medical school, I went to UPenn in Philadelphia and did dentistry. I went to University of Connecticut in America and I did prosthodontics. And I was in the University of Geneva for 18 years to do the adhesive at Magne style. So I have a huge training, and I can tell you this part helped me a lot with the reconstruction. But this part, the medicine, is helping me a lot with the rehabilitation. So the 3-step was, the article was 2005. Nowadays, there is the book. And so what is my 20 years of experience is that I, out of the weak link, I want my weak link to be at the higher level, the simpler to be repaired. Because once the patient is in the red zone, it's extremely difficult to bring in the yellow zone. We never bring to the green zone. And so I want to define where to put the weak link. And I don't want this bridge to be overloaded in the middle. I want a little wire here to break, and I will revisit the load on the bridge before I reposition again a new wire that should be still weak, because must tell me that we are overloading. So no hard material, because if you have a lateral with hard material, you have a fistula and a fracture, because instead of breaking the incisal edge for overload, the patient lost the tooth, because the root fracture was the new weak link, because we make this part stronger. So because I cannot control their muscle nature, my goal is to protect what is the percentage remaining of existing tooth structure. Because once you learn how they chew, you will see that they have a functional conflict all their life. And problems are big when we devitalize and we cut teeth. I want little problem. That's why my weak link, like what you see here, is a not invasive restoration. I keep the existing tooth without touching nothing. So not invasive, additive, because if something breaks, I need to see the underlying tooth structure intact, and I will do a very easy repair. So these not invasive weak link are meant to failure. This is the huge changing of paradigm, because these I call like a tire. I don't know what they do with their life. I cannot control, but I know that I will not elevate the weak link. It will not have a root fracture. If something is overloaded, should be overloaded at the level of the restoration, and they will pay for the repair. And that's why these are my material, the CAD/CAM composite, and this is how it look like. This patient is destroy his anterior teeth, and I just put CAD/CAM monolithic composite. This not invasive. They want to devitalize all his teeth. Not invasive means that I recuperate phobic people. I work without anesthesia, without opening the contact point. And this is the way it looked like after 9 years. 9 years follow-up. There was a little chipping there that I just polish, and the patient knows that once the children are again overloaded, I can remove it or I can add on the adult. And so when the children are overloaded, it's not good. But we do additive, CAD/CAM composite monolithic, provisional on implant, and on implant always composite, because otherwise it's going on the molar, because I want an implant in contact. I don't want a zirconian on implant that is not in contact. And at that point, I can do miracle, because these are built up on this inexistent teeth without post. No tooth preparation. I just add composite. Here, there is no post on that vital tooth, no post. And this is 3 years follow-up with all the occlusal adjustment. He's coming next week for the 4-year follow-up. So in conclusion, I really think you should be on the April 11 and 12 at Kuala Lumpur, because I will not plan to go back. So it's like people that say, oh, I miss you. Can you come back to Argentina? No, because there are all these nature in waiting list, waiting for I do 2 travel a year. So it's not gonna happen a double. And on the website, there are the program where I will really show you how we chew and I will talk about the anterior conflict and the no-Brax classification to help you really to address your patient only with the 10 finger, 2 eyes, ear, the mouth to speak to your patient. You don't need any machine, and that means you can do that to all the patients that are sitting in the chair. So because mastication is the key, the restoration must become the weaker link. This is finished. I don't produce anymore this problem. My restoration, weak and weaker, because my therapeutic objective is the preservation of what they have, protection of the remaining healthy soft tissue. I need to be next to them for the time that they would be my patient. They bring me 80% of their remaining tissue, and I need to protect from themselves. And this is also make me, this non-invasive prosthodontics, sleep much better. If you need more information, just go to this 3stepacademy.com, because I also have practical courses on occlusal adjustment, that this is the reconstructive part that is extremely important, because it's not just to put composite on the back teeth, it's to reactivate the whole organ of mastication. With this, I give you the word to Nurul for the comment, the final comment. And I thank you for your attention.
Thank you very much, Francesca, for a very nice introduction to what we are going to get in April 11th and 12th. I do welcome any questions from the audience. I'm pretty sure Asian audience are a little bit more quieter than part of the world, Francesca. If you all have any questions, can you just type down on the Q&A or on the chat box that we have in this Zoom room. So if you have any questions at all, we can actually answer. Probably Francesca can also answer some of those questions.
Nurul, I will say,
yes.
I will not answer the question. They have to show up, the 11 and the 12, and they have to buy the book, because sometimes I have people that wants to have a fast and furious definition, and I say, no, this is high quality prosthodontics that needs training. So there are people say, no, but just tell me, how do you position the jaw? I say, hey, I take 3 hours during a practical course to train you how to do so. So you will never go to Dawson and say, can you show me in the bathroom? Can you show me how you do the so this is quality. I give free seminar, I give the online lecture. I cannot do more than that. But when I see people that don't want to do the effort to do the 20 years that I try to make a shorter and very, I don't answer. So we will keep you the way it is, not to be not available, but to tell people, you want to know more, come to Kuala Lumpur. This was just an appetizer. So, guys,
appetizer.
Appetizer. There are no discussion, no question. I have every month an advanced training where there are people with me that they ask questions. All the other people cannot ask questions, because this is not a practical course. This is just you want to see, this is what it goes.
Yes, exactly. Thank you very much, Francesca. So we are looking forward to meet all of you in Kuala Lumpur. So if you have any more questions,
don't ask.
Don't
get
ask
the book and answer yourself a question.
Get the books, get yourself registered, so you all can log on and head on to our Dental Academy Malaysia Instagram, where we have a link tree where you can actually register yourself for the course with Francesca, which will be covered in more depth for 2 days, 11 and 12 April. So I am looking forward for all dentists from all over Asia in Kuala Lumpur from 11th April to 12th of April. We will meet Francesca, and if you want to get any of the books, please also get in touch with us So we would be able to get the books here in Kuala Lumpur by the time we meet Francesca in April. If that's all from both of us, that's all from Francesca and me, Nurul. So I will actually see all of you in Kuala Lumpur, and we'll see you, Francesca. Welcome to Kuala Lumpur for the first time. Welcome to Asia. So keep your questions, your list of questions for April, and then we'll get our queen here to answer all those questions. With that, I would like to thank again Francesca and all the team, Jusel and the rest, for setting up this webinar, and I'll see you in Kuala Lumpur soon.
Ciao.
Okay, have a good day.
You too.
Bye.
Ciao.